Hello and welcome to our webinar on application of LSVT LOUD to advanced and atypical Parkinson disease. We welcome you from wherever you are around the world today and are excited to have you join us on this topic. My name is Cynthia Fox and I'll be presenting today along with my colleague Elizabeth or Beth Peterson. Just a few logistics that we'll go over in the beginning of this presentation. One is that there are handouts. These handouts were emailed ahead of time. If you did not have a chance to get those at that email, there's also a way to download the handout in your control panel on your screen, a little handouts button. And you can certainly do that after the fact as well if you'd like to keep a copy of the content that was presented. Our goal will be, after a few housekeeping logistics, to present the content of our program today. At the end, we will have some time for you to answer questions, but feel free to type in your question in your window pane at any time during the presentation. If it comes to you, add your question and we'll be able to address it at the end. At the end of the 1 hour presentation, you are free to exit and there'll be a short survey that will pop up. If you have 2 extra minutes and can fill that out, it's very helpful for us as we evaluate our webinar presentations and plan for future presentations. In some cases, we may go over the hour if there are additional questions. You are not required to stay by any means, so if you need to leave at that 1 hour mark, but if we do have additional questions, we'll be happy to stay on a few extra minutes to be sure they all get answered. As I mentioned, your faculty for today are myself, Cynthia Fox. My full bio is here, but in short, I've been with LSVT for 25 years now and have worked with LSVT LOUD, LSVT BIG. I currently serve as CEO for LSVT Global, and I'm also faculty for LSVT LOUD and LSVT BIG training and certification courses. Beth Peterson is one of our LSVT LOUD experts. She's an LSVT LOUD faculty. She's participated in the LSVT LOUD research for many years and currently serves as a consultant, ongoing consultant for LSVT Global. A few disclosures about our relationship with LSVT Global. We have non-financial relationships, including a preference for LSVT LOUD as a treatment technique, and obviously will be the focus of today's presentation. Financial relationships include both myself and Beth are employees of LSVT Global and receive lecture honorarium. In addition, I also have ownership interest in the company. Today's presentation is available for you to use as a self-reported continuing education activity for those of you who may be professionals attending the webinar today. The webinar is not ASHA or state registered for CEUs, but as I said, it can be used for self-reported CEU credit as a non-registered CEU activity. So if you are a speech therapy professional and would like to self-report your activity, please email us at the end of the presentation at webinars@lsvtglobal.com and simply request a certificate of the webinar, and that will include your name, date, and duration of the webinar. You'll use that for your self-reporting process. Now, licensing requirements for CEUs differ by state. Check with your state licensing board to determine if your state accepts non-ASHA registered CE activities such as this one. Attendance for the full hour of the live presentation is required to receive that certificate. Okay, housekeeping out of the way, let's dig into what we'll talk about this morning. Morning here in Tucson, maybe afternoon where you are. Our learning objectives is that you will be able to define broadly what is advanced Parkinson disease, describe broadly atypical Parkinsonism disorders, and then discuss how LSVT LOUD speech treatment can be customized to meet the needs of individuals with advanced or atypical Parkinson's. So we'll describe the speech characteristics of advanced and atypical Parkinson's. We'll talk about some of the treatment adaptations. Now, these would be things LSVT certified clinicians would be able to do to accommodate some of the challenges that may come with advanced or atypical Parkinson's. And finally, we'll include throughout the webinar 2 case studies to hopefully highlight some of these adaptations and also the improvements that individuals with advanced or atypical Parkinson's can experience following LSVT LOUD treatment. So when we talk about advanced Parkinson disease, we're really talking about the later stages. If we put that in context of the Hone and Yahr scale, which is a common scale used to stage Parkinson disease, you see it goes from stage 0, no signs of the disease, stage 1, early unilateral disease, through stage 2, 3, and stage 4 and 5 would be the characterization of advanced Parkinson disease. This is where individuals may be experiencing more severe disability, but they're still able to stand or walk unassisted in stage 4. Stage 5 would be wheelchair bound or bedridden unless unaided. Some other characteristics that tend to come along with advanced Parkinson's disease is the onset of motor complications, despite aggressive pharmacological and behavioral management. These motor complications might include things like wearing off of the medication, so you get on-off fluctuations. There may be more dyskinesias in response to the medication and more overall drug failure response. So the same improvements that were previously experienced with medications may not be the same. In addition, there may be cognitive issues that become more prominent, things such as hallucinations, which may be secondary to medication and sometimes can be treated with medication alterations, the onset of dementia, and perhaps more memory challenges. Medical treatments in advanced Parkinson disease may include deep brain stimulation. This may be used when dyskinesias are severe due to high doses of dopaminergic drugs. Careful cognitive screening and careful screening overall is required for consideration of deep brain stimulation at any point for a person with Parkinson's disease, but may become even more important in advanced disease conditions. Even after deep brain stimulation, we know that individuals may still be prone to falling, freezing of gait, balance issues, and voice speech may not be improved as much as other symptoms with deep brain stimulation. And in some cases, speech symptoms may actually get worse. But all in all, the DBS can be very valuable for people who are experiencing dyskinesias and a lot of on-off symptoms. Pharmacological treatments may become less effective overall. Again, there may be increased off times, more side effects, and more or different types of pharmacological therapy may start to have to be added to effectively manage symptoms of the disease. In terms of atypical Parkinson's, so how are they different? And perhaps you're familiar with atypical Parkinson disease. Some of you, this may be a new terminology, but let's talk about how they're similar and they're different. First of all, they have one or more features similar to Parkinson's disease. These may be the classic signs of rigidity, bradykinesia, tremor, or postural instability. But they also have added symptoms that may or may not be seen in classic Parkinson's disease. And that's where another term sometimes used is Parkinson's plus. The disease course and underlying pathology differ from classic or idiopathic Parkinson's disease. Oftentimes, these different atypical Parkinsons do not respond as well or in the same way to anti-Parkinson medication. And they can definitely be difficult to distinguish from Parkinson's disease initially. Some of the most common atypical Parkinsonisms include PSP, progressive supranuclear palsy, MSA, which is multi-system atrophy, cortical basal degeneration, or CBD, Lewy body dementia, or LBD. And I'm just going to give a very high level overview of these different types of syndromes. So for progressive supranuclear palsy, some common characteristics are falls, frequent, sudden falls, and this can occur early. These falls may also be posterior. So there's a term called retropulsion where the fall is backwards. Ineffective medication. So again, Parkinson medications may not be particularly helpful. There can be gaze palsy, which is vertical gaze palsy, and typically downward gaze is initially effective, and speech and swallowing changes, which we'll talk more specifically about in a few moments. Multi-system atrophy is exactly that. Multiple systems are experiencing atrophy and change. Some of the different types of multi-system atrophy are MSAP, which is a Parkinsonian. So there's a striatal nigral degeneration, implies Parkinsonism with some degree of cerebellar dysfunction. These individuals may look more classic Parkinson's with slow, stiff movements. MSAA tends to attack the autonomic system more. So Shy-Drager syndrome reflects a predominance of autonomic failure along with some of the Parkinson-like symptoms. Orthostatic hypotension, constipation, urinary incontinence are not uncommon. And then MSAC indicates cerebellar. So olivopontocerebellar atrophy indicates primarily cerebellar deficits with minor degrees of Parkinson's. These individuals will experience more ataxia, balance, coordination, and gait challenges, and speech challenges. Cortical basal degeneration, CBD, is more characterized by cognitive changes, once again, ineffective medication, an asymmetrical presentation, and in some cases, the development of apraxia. And apraxia is the inability to perform coordinated movements, such as speech in some cases, but other types of movements or use familiar objects. And then odd movements or feelings, slowness, stiffness, shakiness, and clumsiness. And finally, Lewy body dementia obviously has more of a cognitive component as well. So fluctuating cognition, visual hallucinations, along with features of Parkinsonism. It's often with rapid progression of postural changes, generally trunk flexion and or lateral flexion. But there's progressive cognitive decline within 12 months of onset of the Parkinson features. Some other general points related to atypical, as I mentioned before, it can be difficult to diagnose initially. Sometimes it's a wait and see. We have a Parkinson initial looking symptoms, perhaps follow over time. It's when the recognition, the medication is not as effective and the symptoms are progressing more rapidly that eventually an atypical diagnosis may be made. It's not managed well with medication or surgical treatment, which is why rehabilitation, in particular speech, physical, and occupational therapy, is so important in the management. Individuals, again, rapidly progress through the disease. Symptoms and presentations can vary greatly from person to person. Compensatory strategies in terms of rehab may need to be implemented earlier versus restorative treatment methods. We want to, again, begin therapy as early in the diagnosis as possible so that we can help individuals learn behavioral strategies they can use and hopefully help them manage the symptoms better through the disease progression. We also know that as rehabilitation professionals, we may need to follow you more regular. So instead of a course of treatment and perhaps waiting 6 months to see you again, maybe we want to see individuals once a month or every 2 months for more frequent tune-ups. It's important to involve the whole team, and that may be spouses, family members, friends, so that they have education and training on behavioral strategies that can be the most effective. And helping individuals establish this care team early. And so if we can be a part of that team and help develop that team as speech language pathologists, we can help patients manage as best as possible. So what are the speech characteristics in advanced and atypical Parkinson disease? In terms of advanced Parkinson disease, some of them are what we see even in early Parkinson disease, they've just progressed further. And so things like a soft monotone voice, hoarseness, breathiness can all be there. Sometimes the mumbling or imprecise articulation gets worse. There may be vocal tremor, and we may see an increase in disfluent or hyperfluent speech. So disfluent speech can be a stuttering-like, where there's initiation difficulties or inappropriate silences. But also there can be a component of hyperfluent speech. These are defined as compulsive, effortless repetition of words and phrases against a background of increasing rate and loudness. Word and phrase repetitions tend to occur at the end of an utterance. And in the case study that Beth will be presenting, you will hear a gentleman with advanced Parkinson disease that definitely demonstrates some of this hyperfluent behavior. Individuals may also just need increased time for processing information and for responding. So one of the strategies to keep in mind is give them the time they need to process what you've said and respond before talking over individuals or responding for them. In terms of deficits in atypical Parkinson disease, these speech and swallowing changes tend to occur earlier, are more severe, and progress more rapidly. The presentations can vary, but it's more of a mixed dysarthria. So a dysarthria is a term, again, that refers to this motor speech disorder that can occur in many types of neurological disease. In individuals with Parkinson disease, it's a hypokinetic dysarthria, which is characterized by soft voice, monotone, monoloudness, and imprecise articulation. When we get to atypical Parkinson's, different types of dysarthrias that are more mixed in presentation tend to appear. So it may have some of that hypokinetic component plus ataxic or spastic components that might manifest as more strained voice quality, impaired fluency, more slow rate, and in some cases palilalia. And we'll also see a video example of a gentleman with palilalia later in the presentation. Language deficits, linguistic and cognitive processing are also considerations that these things can change and affect communication, which when you put it together, there's just overall greater communication deficits. And this can be things like initiating speech, just managing conversations, that turn taking and shifting of topics. This slide was from a study by Jan Roos and his colleagues in the Czech Republic, and they looked at speech characteristics that may be differential diagnosis of atypical Parkinson's. So what you have on the x-axis is three different groups of individuals. The first grouping is individuals with progressive supranuclear palsy, the middle grouping individuals with multisystem atrophy, and the far grouping individuals with idiopathic Parkinson disease. If you look at the idiopathic group on the far right, you see the majority of individuals have mild dysarthria severity, some moderate, some more severe. When you compare that with MSA and PSP, you see a much greater percentage of individuals with more moderate to severe presentation of dysarthria than typical idiopathic. When we're looking at the type of dysarthric or speech components, again, those characteristics that are hypokinetic, typical Parkinson disease, spastic, which may have more strain type of voice quality, or ataxic, which may be characterized, I'd say, by more slurred type of speech, impaired tongue control. Again, on the far right hand of the graph, you see individuals with typical idiopathic, and they predominantly all have a hypokinetic presentation. In contrast, when we look at PSP and MSA, you see this combination, with PSP having hypokinetic and spastic predominance with some ataxia, whereas MSA may have predominant ataxic type of speech characteristics with spastic as well as hypokinetic. So I think the take-home message is that the presentation of the communication challenges are different in these atypical individuals. Let's listen to 2 audio samples, first of a person with PSP and second with a person with MSA. So again, in progressive supranuclear palsy, there may be increased disfluency, decreased slow rate, more silences, deficits in vowel articulation, and in some cases, a more harsh voice quality. So we'll listen to this first speech sample now.
Start right here. Go ahead.
The sunlight strikes raindrops in the air. They act like this is informational. Rainbow. I into the colors. These take the shape of a long brown arc. Pant, pie, and 2 hands. Apparently, beyond the horizon, there is a corner that is pilot and
Okay, so I think you could hopefully hear some of the severity of the speech challenges. Very soft, greater silences. She was reading a standard passage, difficulties in vowel articulation, and the slower rate. Next, we'll listen to an individual who is diagnosed with multi-system atrophy, pitch fluctuations, sometimes excess intensity variations, and that may be associated with those who have more ataxic type dysarthria. Prolonged phoneme, some vocal tremor, and in some cases a more strained or strangled voice quality. We'll add that this sample came from our colleague Dr. Elena Tripoliti in the United Kingdom, so we also have a British accent.
What did you see? Can I please have a drink? I'm ready for my 7 o'clock pills. Is it the porridge for breakfast again? Can you get my wheels out of the garage? What's for lunch today? I think it's time for a cup of tea. Can I go out into the garden? David, can you wake up and stop snoring? I'm going up to bed now.
Start right here. Go ahead.
Sorry about that. Oops. Okay, so with that little bit of overview of what entails advanced and atypical in terms of symptoms and speech characteristics, let's talk about what we can do to improve communication. And certainly the take-home message is we can have effective strategies to improve communication. Our goals really are to maintain and improve the physical capacity. This is where we like to get people as early as possible, again, post-diagnosis, work on improving loudness, voice quality, speech intelligibility, and rate strategies. We also want to maintain vital functions, and that may be, while this presentation is mostly on speech, we also can address swallowing. Functional communication becomes very key, so that individual treatment approach to understand what's most important to each person in terms of communication and communication goals. In some cases, as disease progresses, we may need to augment verbal communication, oral communication with external cueing devices or augmentative communication devices, and again, addressing cognitive and/or language deficits. So our motto is treat early and as needed, treat often to give the most successful communication strategies. At this time, speech treatment research in advanced and atypical Parkinson disease is very limited, but there are some data that would support us in utilizing strategies like LSVT LOUD. There was a case series published in 1994 that looked at LSVT LOUD in a case of progressive supranuclear palsy and multi-system atrophy. In 2015, a group in Italy published a nice paper showing positive outcomes in a group of individuals with progressive supranuclear palsy. And most of our trials, our randomized controlled trials, have included some individuals with advanced Parkinson disease. And our recent RCT that was published in 2018 to quote, the ability to generalize these findings to patients with more advanced disease is supported by our findings of no significant associations between time post-diagnosis, which in the study ranged from 0 to 31 years, and with in-group treatment-related changes in sound pressure level, which is a measure of loudness, through 7 months. This suggests that regardless of disease severity, patients showed similar treatment-related improvements within group. So now what I'd like to do is turn it over to Beth, who will walk you through some case studies and adaptations that help make LSVT LOUD as successful as possible.
All right, great. Thank you so much, Dr. Fox, for that really helpful overview there. So I'll jump in and we'll start with a case study here. So for this case study, we have a 67-year-old male, and the diagnosis at the time he was seen was advanced Parkinson's. So he was stage 5 on the Hoehn-Yahr scale that Dr. Fox presented. And at the time he was seen, it was 17 years post his diagnosis. The main voice and speech symptoms for him were significantly reduced volume, imprecise articulation, and an accelerated or rapid rate of speech. And the overall speech impairment rating for him was severe. He was a participant in one of the research studies. So on the next slide, we'll hear his audio sample, and you'll hear both his pre to post audio sample after doing LSVT LOUD. So we'll go ahead and play that one so you can hear him.
You're diagnosed with Parkinson's. When was that diagnosis made?
1978.
Okay, what were your first symptoms?
First symptoms was like uncomfortable sitting down on a bench.
When did you first notice a change in your speech or your voice that you would associate with Parkinson's?
I didn't notice it. My wife noticed it.
And when did she notice it?
Oh, probably 84, 85.
Okay, very good. Count from 1 to 25 for me.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 25.
And now post-treatment.
Count from 1 to 25 for me.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
Oh, they told you it's easier to understand you?
Yes.
Who?
Oh, my daughter-in-law, my wife.
What have they said? Tell me that again.
I said I understood.
Is that right?
Yeah, I hope so.
All right.
Okay, so I hope you can hear and appreciate the difference between his pre to post. We could really hear some nice improvements in the loudness, and as Cynthia mentioned earlier, in this case study, you could really hear that rapid or fascinating speech. It doesn't completely go away, but we really hear a nice functional difference, made a big change for him. The slide you see in front of you shows the outcome data for him. So what we're looking at is decibels of sound pressure level, or the vocal loudness. So we see that on the y-axis, and then on the x-axis we see pre, to post, and then up to 6 months follow-up. And we're looking at the ah exercise, a reading exercise, and then a monologue. And so we see some nice improvements from that pre to post, maintaining out to that 6-month follow-up for him. So again, really made some nice differences after the 4 weeks of treatment for this gentleman. So we'll go ahead and talk about some adaptations for advanced or atypical Parkinson's. And so what we really want to point out here is that what adaptations are versus what they're not. And a big takeaway here is that any adaptations we do for the more advanced clients are not taking away or altering the protocol. Rather, we're helping adapt the sessions so that the clients can complete the full protocol. So the adaptations that we list, some suggestions that can be helpful, are increasing repetitions for shorter duration so that clients are still getting the same amount of time of practice for the exercise, but maybe they need to do extra repetitions, or I should say more repetitions in that amount of time, because their trials are not as long as some other clients. There might be greater rest breaks in between trials. When we get to the level of the hierarchy, at the second half of the session, we might be working at the phrase and sentence level even into weeks 3 and 4, when typically in week 4 we're getting to the conversation level. Some of these clients, we never get to full spontaneous conversation, and that's okay as long as we're making that big functional impact for them at whatever level, phrase, or sentence that it may be for them by the week 4 of treatment. We might utilize family and other support systems more for carryover, so really educating and keeping in contact with the family, being able to check in on how things are going outside of treatment, and then making sure that we're really educating family and other members for this person on what would be appropriate kind of methods of cueing or support at home. We might have to alter materials for visual or language impairments, and we have a slide on that coming up, so I'll go into more specifics for ideas on that. We might also have to add additional sessions at the end of the 4 weeks and more frequent follow-ups. So it might be the client goes through 4 weeks, you think, oh, if I could just have 1 more week with this client, I think I could really push them to the next level, and maybe you can add in another week of treatment. And then we're following up with them maybe every 1 to 3 months to see how they're progressing and if they need to come in more often for some tune-up sessions. So then in terms of what adaptations are not, so again, we're not altering the core protocol. They're still going through the same exercises as someone that was not as advanced or severe. We're not delivering fewer or shorter sessions, so there's still 4 sessions a week, 60-minute sessions for 4 weeks. And we're not changing the treatment task. So they're still going through the ahs, they go through highs and lows, they go through functional phrases, and a full speech hierarchy. So they're still getting every treatment task. And we're also not eliminating those core elements. So we're still focused on vocal loudness, even though you've seen from previous slides that there may be other areas of communication that can be improved. We're still only focusing on loudness, and through focusing on loudness, we're working on a spread of effects to those other areas as well. So again, the mode of delivery is still going to be intensive for these clients, and we're still working on calibration to make sure that changes we see in the treatment room are going to walk outside the treatment room and last over time. In terms of, we'll kind of break down each of the different exercises and talk about adaptations specific to those. So for the maximum duration sustained vowel phonation, or that long loud ah, as a clinician, you may need to spend more time shaping and modeling that good voice quality during the ah. Some other clients may get it right away. They can do an ah with very minimal modeling or shaping. For some of the more advanced clients, there might be some more back and forth between the clinician and the client. The durations, again, may be shorter. So maybe there's just 2 or 3 second ahs. And so you're going to do more repetitions of those shorter ahs so that the client is still getting that full 12 or so minutes in the beginning to do that ah exercise. So they just might get more repetitions. You might have to allow longer rest periods between the repetitions. You might have a prolonged need for modeling and shaping, and you may use that ah more frequently for resetting vocal loudness. So maybe as you progress in the session and you start to get into reading or any type of conversation practice, if the loudness drops, you may need to more often come back and say, okay, let's do ah, what's for dinner, and kind of pair that ah with a phrase so that they can get back into that ah voice. For the highs and lows, or that maximum fundamental frequency range, the pitch range may be very reduced. So it might be harder to really expand that range as some other clients that you may have seen. And that's okay. It's an exercise of working to change the pitch. So whatever pitch change you can get, even if it is minimal, we're still working, and we're still working every session to make it as best as possible for that client on any given day. There might be a greater tendency to not start at that max ah, or that kind of that modal ah pitch and that good loud voice for the max ah. So you may need to reset that exercise more frequently. So again, you may do a few highs and then say, okay, let's come back and do ah for a few seconds, and then, okay, great, now let's start there and then go high. So trying to get them back into that max ah voice. Again, for this one, you might have more clinician modeling and shaping to get the best voice for that client. And next, for the functional phrases, you may need to use family members to help create the phrases. And again, we want to make sure that if you are using family, it's important that the phrases truly are what the patient does say every day, and not what a spouse or another family member wants them to say. So we still are getting client input, but we might get some family input as well. But again, really working with the family and the client to make sure that they're phrases that the client truly says. For these, you may also utilize increased repetitions. So typically for other clients, we're going to have them do 10 phrases 5 times every session. But maybe because these are so key into their functional impact on their daily living, you may use more repetitions of these so they really get those functional phrases really nailed down, because that's what the key phrases that they're going to be saying outside of treatment are. You may also increase the number of functional phrases and use some of those as hierarchy practice. So once you get into the second half of the session, you may still be doing some of those additional functional phrases, again, because we really want to practice what they're going to be saying outside of treatment. And it might be those functional phrases that really become key to making that big difference outside of treatment. In terms of the speech hierarchy, or that second half of the speech session, it's important to still maintain salient practice. So really making sure the materials you're choosing are salient and personalized to the patient that you're working with. And you can again use family for input on what some of these exercises or I should say some of these tasks or reading materials might be. So what is important to the client? What do they like to do? What are their interests? What helps them maintain safety and good quality of life? So really thinking about what can be salient for them at each level of the hierarchy. And continue to include both structured tasks and spontaneous speech. So at the end of a session, maybe the last few minutes, you can work in some spontaneous speech at the same level of the hierarchy where you're practicing your reading materials, so that you can get some spontaneous speech, even if they'll never get to a full conversational speech level, but they can do that spontaneous speech maybe at a phrase or sentence level. And making sure that you're allowing sufficient time for slower cognitive processing and response. So maybe there are longer pauses in between questions you're asking or the phrases that they're reading or whatever it may be, making sure that you're giving them the breaks as needed for rest, but also for that cognitive processing. And again, with this, you may have to go back and use that ah as needed to rev up the system again. So it might be by the time they get to the hierarchy or towards the very end of the session that they are losing that power or that volume. So you might say, okay, let's try another ah for 3 seconds. You get that good ah voice. Yes, that's the voice I want you to use every time you're saying any of these words or these phrases. So again, maybe going back to that ah again to get that system up and running again. So next we'll talk about what about if clients can't read or if they can't see, if they have some visual impairments, and this may be due to language disorders or a visual impairment, illiteracy, or cognitive decline. So the goal with this is that you're still translating that reading practice during the speech hierarchy into speaking practice without the need for written words. And that would really be for any client, because we really want to get them to that conversational or spontaneous speech level. So we want to match the output in terms of the length of utterance to the level of the hierarchy. So whatever level of the hierarchy you're working on, whether it's words or phrases, sentences, paragraph, or conversation, that's what you're trying to elicit with the prompts that you're giving to your client. So if the vision is intact and it might just be difficulty with reading, you could try pictures. You could have pictures, you know, the first week when you're in the word level, you can say, you know, point, or I'm going to point to every item in the picture. I want you to tell me that item. The next week you might say, you know, when you're at the phrase or sentence level, you know, tell me one sentence about this picture. And again, you can progress through the 4 weeks of treatment that way. And by the 4th week, you can say, you know, describe everything that you see in this picture. You're still maintaining the intensity of motor practice, even if you're using different types of materials, because we still want to make sure that they're getting that full speech hierarchy practice for the second half of the session. So this breaks down kind of week by week some of the ideas that you can think about for these clients. So when you're at that word level, clients can generate lists based on topics that you provide. They can finish short sentences with a single word or a short phrase answer. They might name opposites listed by the clinician. So again, you can say, you know, I'm going to give you a category. I want you to tell me 3 items in that category. So fruit, and then they tell you 3 fruits. You might start a sentence again and they finish that sentence with a word that would fill in the blank, or again, naming opposites. At the sentence levels, you could provide a word and then you would have the client describe or comment on, you know, 1 or 2 sentences. So, you know, trying to think of so an animal. So I want you to describe a bunny rabbit in 2 sentences, or whatever their interest may be. And then you're leading them into, again, the output that you want, just as if they were doing it as a reading material. So for paragraphs, so this is typically the 3rd week of the hierarchy. So you want to be stimulating a little bit longer speech, but keep it somewhat constrained. So again, more structured practice. So you can ask the client questions about maybe their family, work or hobbies, sports, whatever their interests are, and then ask them to respond for 1 minute or 2 minutes. So again, you're still kind of structuring that task more than if it was just open-ended conversation. When you get to week 4, or when they're into conversational practice, you would do the same types of exercises as you would with a client who did not have impaired vision or who was not able to read the materials, and this would be more open-ended conversation. In terms of calibration, so again, calibration being the idea that you're calibrating the patient to this new effort and loudness from treatment so that they use it outside of the treatment room. So with these clients, it can be more challenging, but it remains just as important because they need to know the effort that it takes to use that voice outside of treatment so that they can and will use it with family and friends and restaurants, wherever they may be. Education, the education component of calibration may be a little more difficult because of some cognitive impairments, but also the differences that you play back on audio may not be as easily perceived as some of those clients who are not as severe. And also benefits and rewards of this improved communication may be harder to establish. So again, you might have to be more motivating, really getting in there with that calibration and keeping it up, and not giving up yourself just because you're not seeing your client maybe getting or understanding those rewards as much as you have with other clients. But it is still so critical to work on that calibration, especially with these populations. So you want to really find those emotionally salient opportunities so that they can feel the reward of that improved communication. So really jump on any calibration moments or aha moments that you can to really help them understand and see and hear that difference. And then just thinking of adaptations in general, with these clients, you will likely need more support from family, caregivers, nursing staff, depending on whatever living situation they're in. And you could also include more family or caregiver perceptual ratings to help determine the functional impact. So maybe at pre and post treatment, and maybe even at mid treatment, you can give some of those rating scales out to others to see how they're doing, again, outside of treatment, how others are viewing the differences that you're helping with during the treatment month. And then also when you're working with others, family members or staff, make sure that you're working with them and educating them on what would be appropriate cueing. So for example, if you're in week 1 of treatment, you're working on the word level, you can educate family members on When your client says, something at the word level, you can go ahead and give them the cue, oh, can you say that louder? But you don't want them doing that for every single thing the client says, because they're not at that level yet. They've just begun treatment. So making sure you're educating them on how to cue appropriately based on what you know that the client is capable of, whatever week you are in treatment. And the same thing would remain at the end of treatment. Depending on where you get with your goals, you can educate the family or other members on how to appropriately work with them or in the patient at that level, as opposed to kind of becoming nagging or just too inappropriate that it's not at a level that the client can maintain. So islands of lucidity. So when the client is doing really well, really capitalize on that, get that client motivated, really show them the difference. But we also like to treat these clients at times when they may not be present or they're just not feeling their best, to really show them, even when you're not feeling your best, you can still make a big difference in your communication and others can still hear and understand you. You might have some motor fluctuations, so on and off periods with their medication, dyskinesias from the medication, and then making sure that you're acknowledging the client's fatigue within your treatment session. So yes, we still push them to those high effort levels, but we can also still validate the client. Ooh, I see that was a lot of work. I see that you're tired. Let's take a quick break and let's do it again. And again, with these clients, you may have to have longer rest periods to get through all of the exercises. In terms of treatment location, so some considerations you want to think about would be cognition, so the cognitive level, distractibility, so are you in an office with minimal distractions, or is there a lot going on in the background that can make it difficult for the client to focus? Thinking about treating in the home environment versus the clinic setting. So if you can treat in the home environment, that can be great because you have so many salient opportunities in the home. If you do treat in the home, again, just making sure you're in a room with limited distractions though there as well, to make sure the client can really focus on treatment. Working with the client on any transportation issues. So do you need to set up a carpool with their church, or just really make sure that you can get that month of treatment scheduled? Can their spouse take them those days? Again, just helping work through any of those issues that can get in the way of them doing the 4 weeks of treatment. There's also the possibility of adding telehealth sessions to reduce the fatigue from traveling. So can you just do half the sessions over telepractice so that they don't have to come in for all 16 sessions? So that might be another possibility to explore, again, so that they don't have all that fatigue from coming in for 16 sessions. So in terms of cognitive concerns, so we talked a little bit about making sure the room has as minimal distractions as possible, keeping it separate from others so they can really focus on treatment. Do treatment without observers, especially those early sessions, so that you're really getting work out of the client and not someone else trying to help the client, like a family member or nursing staff. And then model the exercises how you want the client to perform them. So exactly how you want them to do it, so that you're really showing them through your model and limiting your clinical explanations. And this is something we do with all our clients, but it becomes especially important when we work with these clients who may have some cognitive disabilities. Using environmental cues to help the client with the exercises, and really hammering home that repetition, repetition, repetition. So making sure they're getting that good repetition, because they're really going to need that to take what you do in treatment and take it outside of the treatment room. Keep the focus simple, even when other communication deficits are present. So again, all your cueing should be on loudness. Even if you're trying to work on articulation or rate, you're keeping the focus simple and only on loudness for the client. Whereas the clinician, you may be thinking about, okay, how can I slow down the rate? Or, how can I improve the articulation through my model? But your cue to the client is always loudness. You may likely treat some patients beyond the 4 weeks to really make that best functional impact that you can. Once a client is able to follow your clinician modeling, the clinician should educate the care partners, either whether it's family or, again, nursing staff, so that they can become a coach in other environments for the client. We'll also talk about LSVT LOUD Plus, or something in addition to the typical LSVT LOUD 16 sessions. So again, you may need more treatment sessions at the end of the 4 weeks. You may do more frequent and continuous follow-up. So it may be, instead of checking in at 6 months, recommend checking in between 1 and 3 months with the client, and then continuing with that as you follow the client. You may need to use other types of devices for these clients at the end of the 4 weeks. Maybe that wasn't enough to go through the 4 weeks of treatment, so maybe they'll have an altered auditory feedback device that can help them with speaking outside of treatment, or an augmentative device supplementation. So with these clients, it may be that they still need a little something extra at the end of treatment. A pacing board can be helpful for clients, and we'll see that on the next slide. We'll see an example of that. These clients might need additional cues, so perhaps if their rate is slow, you could have a cue for them, loud and fast, and so that's the cue that they take away from treatment. So the next slide, we'll see a video example. This is a gentleman. You'll see him pre and post treatment, so you can get a sense of his speech pre to post, and post treatment you'll see him using a pacing board in addition to doing his LSVT LOUD exercises.
The happiest days of my life is when I try a call from the Navy. And this is playing that's from some days of the fall and my other and I'm approaching the ship and I just wiped out. So that's really so happy.
Tell me a little bit about your experience here. This is session 15. We have one more session tomorrow.
Yes.
Tell me what you've learned from the therapy that you've done.
So still learn how to down and talk slowly. Use this board.
Okay. I want you to say that again using the board.
I learned to use this board to slow myself down.
Good.
Okay, so pretty neat improvement that you could see there to help with that rapid rate of speech. When he had the pacing board, he would point to the first letter of the word that he was going to say, and that was a tool that he could use in and outside of treatment so that he could be more easily understood. The next case study we'll see, this was a 74-year-old bilingual female, so English and Spanish. Her diagnosis was PSP, or progressive supranuclear palsy, stage 4 on the Hoehn-Yahr scale. Her main voice and speech symptoms were reduced loudness, monotonicity, strained voice, lower pitch, slow rate, reduced breath support, and imprecise articulation. So you can see that there's a lot of symptoms going on, but treatment would still focus just on vocal loudness and cueing her for vocal loudness. The overall speech impairment rating was moderate to severe, and the oral mech exam revealed reduced range of motion and coordination of her oral musculature, but the labial, so the lip and the jaw strength were normal. So the next slide, we'll see the ENT exam results showed moderate vocal fold bowing and moderate severe false fold hyperreduction. And then they did some patient and family ratings based on conversation regarding her attention, memory, ability to engage in conversation, and also included some medical reports from the doctors and also psychiatrists. And there was a significantly reduced communication ability and initiating and maintaining conversation. So with her, we kind of are going to walk you through next steps of what we're done with her. So the stimulability testing was done as part of the evaluation to see if she'd be a good candidate. For that, she needed max models and cues, so they used the cue of shout to get her to the best vocal loudness that they could for her, and she was able to participate and do the exercises. So they did a 1-week trial of LSVT LOUD as if they were going to do all 4 weeks, and during that week they prepared materials and set up the materials to compensate for her visual difficulty. So she could read, but she couldn't move her eyes up and down. So to compensate for this, they held and moved the materials for her. The font was bold and making sure that there was adequate spacing between the letters and lines of text. So just some things to do to make it easier for her to to see the materials. After the end of that 1-week trial, and because she had good simulability results, they went ahead and proceeded with the treatment. And some adaptations that they did during the treatment sessions is they adjusted her goals following 2 weeks to account for that difficulty reading at the paragraph level. So they continued that practice at the phrase and sentence level for the remaining 2 weeks. So her end goal was something at the phrase or sentence level, as opposed to that spontaneous full conversation, which for her was still wonderful because you could still make that big functional impact. So she had great family support. They were encouraged. They didn't want to stop doing treatment, and she was continuing to make progress. So at the end of the 4 weeks, they added another 2 weeks, and then another 2 weeks after that for 4 additional weeks of therapy, and she had a really great outcome after that. So they were also making sure they established a good homework routine, so a good time, place, making sure she was accountable for doing it. And they did this during daytime, evening, and weekend aids, as well as the husband, so they had that great support so that she could continue doing this outside of treatment. And those members were also trained on what would be appropriate cueing for her. In terms of maintenance, so after treatment, so they established a good lifelong relationship, and they had more frequent and continued check-in. So there was a 1-month break, but she continued to do her daily home exercise plan, and she did that consistently. They checked in at 1 month. She was doing well. So at the time of the 2nd month follow-up, the client had declined a bit. So they reassessed and recommended her coming back in for some tune-up sessions 2 times a week for 2 weeks. And the family continued to do this for some time. There was another break with a medical decline, and then they resumed to preserve the remaining function, develop an AAC or augmentative communication device plan, and then also to monitor and address the swallowing issues that were going on with her. So she did have some deterioration in her condition, but they were able to work through that with a maintenance plan. So some lessons learned. First, treatment can make a huge functional difference, so make a big impact on her life. So the client was able to incorporate the techniques from LSVT LOUD into her spontaneous speech post-treatment, even if it wasn't at a long conversation level. The husband reported that the client was able to use a normally loud voice with clear speech when speaking with her husband, the doctor's aides, and over the telephone with a sister in Spain. And after 8 weeks, the husband stated she had a nuanced conversation with her sister in Spain on the phone, which is something that she could not have done before. So it really made a big functional difference to her. So that continued homework and follow-up practice is very important, especially for these clients who are more severe. They really need that daily routine continuing after treatment. It's important to be in contact with their whole medical team so that you can also help monitor that decline. And the post-treatment results were similar to idiopathic Parkinson's, but they didn't maintain out to 6 months like we do see for those earlier stages or idiopathic Parkinson's. So those additional weekly sessions that she did after the initial 4 weeks were really important, and then also monitoring her more frequently after treatment was very important too. So we say don't give up. Clients with advanced or atypical Parkinson's likely need more versus less care, and they can really still achieve some wonderful gains and improvements for their quality of life. So in summary, we'll wrap it up here and just say everyone should be given a chance. So we say not to discount successful treatment options just because the disease or the client is advanced or more complex. And so trying out that simulability testing in a week of trial treatment can really be a good way to see if LSVT LOUD can make a functional impact for certain clients. The outcomes can be very impressive, and you could hear some samples and see some samples from the webinar here today. And we say that functional oral communication of any kind can dramatically improve quality of life, even if supplementation is required. So making any type of difference in that functional communication is really the goal and can have such a big impact on these clients. So LSVT LOUD can be applied to all stages of Parkinson's and be customized to each client's needs and the different treatment settings. It can help increase their independence, quality, and safety with communication. So we say restore function, improve function, maintain function. So meet that client where they are and then do the best you can to improve them to the next level. So atypical and advanced Parkinson's, you've heard, can carry unique challenges, and we hope that we're arming you with some creative solutions to help proceed with treatment, or if you're a client, then going through with the treatment, and then also knowing that you'll have increased caregiver involvement. We have on the next slide some organizations that you may want to check out related to these conditions that we've discussed. So there's Cure PSP, the MSA Coalition, the Association for Frontotemporal Degeneration, the Lewy Body Dementia Association, and the Alzheimer's Association. So these websites all have some really great resources for these various conditions that we've discussed. So we're right at our hour, so if you do need to sign off, feel free to sign off. You'll still be able to get a certificate if you request one for being on for the hour. But if anyone does want to stay on and ask any questions, Dr. Fox and I can stay on for a few moments and ask some questions. And you can ask a question a few different ways. You can either type your question into the chat box on your webinar control panel. You can raise your hand and ask your question out loud. We'll just unmute your microphone and call out your first and last name. And then you can ask your question. And if you think of questions after the webinar, or you just have to sign off now, you can always email additional questions to us at webinars@lsvtglobal.com. And before we let you go, we just want to make sure you're aware of our next webinar that we have in October, and that's on deep brain stimulation and LSVT Loud. So we'd love if you can tune into that webinar. You'll get an email after today's webinar that will include a link to register for that webinar if you're interested. And then also if you go to our website, lsvtglobal.com, there will be a link to register there as well. We'd love to have you again at another live webinar if you're able to join us.
Great, thank you, Beth. I just have 2 questions that came in, so I think we can take those again. If you need to drop off, no problem. The first one I'll take, and the second one I'll pass to you. And the first one is, does insurance cover treatment? And we just had a webinar for our LSVT Loud certified clinicians last night on insurance, and the short answer is yes. It is reasonable and necessary care. And certainly if you have Medicare, it is a coverable and reasonable and necessary service. Private insurance, in many cases, as long as you have rehabilitation in the policy, it can cover. And your speech therapist should be able, the speech therapist, along with individuals perhaps in their business office, help walk you through the process. And the most important thing that we need to do as professionals is show why these services are necessary, why the skill of a professional such as a speech language pathologist is required, and have good documentation in terms of improvements or maintenance changes that we're seeing over time with treatment. The second question, and Beth, I'll let you take a first stab at this. Is there ever any case where it simply does not work? So is somebody so advanced or severe that speech treatment is no longer successful?
So yes, it's not to say that LSVT Loud is going to necessarily work for everyone, but it's certainly something that we would recommend doing the evaluation and doing that simulability testing to see if there's anything that you can get out of that client, to see if you can improve their oral communication on their own. So like that second case study, they saw that there was some improvements in simulability testing, and it might not be to the same degree as clients who are not as severe. But if you see anything that you like, then we do say go ahead and try that week-long trial of treatment. And that can almost be, you know, another week of simulability testing in a way, because you're seeing, okay, if I model, if I cue, if I just focus on loudness, can I pull anything out of that voice to make their communication more functional? So I would say it's always worth it to try it and see if you can make a difference. You know, at the end of week 1, if you're not seeing any difference, then I would say there certainly may be clients where it just may not work, or you know, there may be other clients where maybe they would do the full course of treatment, but again, maybe they're still going to need some supplementation. So maybe they still do need an AAC device, so that augmentative alternative communication. But I guess my short answer would be, I think it's always worth it to try that simulability testing and really cue and model just as you would in treatment, to see if a client can make any type of improvement. And if so, then go ahead and proceed with that week-long trial of treatment. Because I would say, and we had this in one of our summary slides, that yes, give everyone a chance, because you may think you know, a clinician may walk in and think, oh, there's no way I can get them, you know, to an improved level, and you may be very surprised at what some of these clients can do.
Perfect. Excellent. I agree with everything you say.
Great.
Okay, well, that brings us to the end of our presentation. We thank you all again for attending. If you have 2 more minutes and can complete that survey, we welcome you to do that, and we look forward to having you at a future webinar. So thank you very much, and this will conclude our presentation for today.